I'm going to present you the 5-year real-life experience of our department in Atlas for the use of coated balloons for the failing dialysis access. It all started back in 2010 when two very important papers in the New England Journal of Medicine. One was for coated balloons in the infrainguinal lower legs and the grafts in dialysis access. They said that both cases had superior results, and then we thought, okay, why don't we use then coated balloons in dialysis? That's what we did then, and we did our first randomized controlled trial for coated balloons in dialysis access to compare the safety and effectiveness of these balloons versus plain balloon angioplasty for the treatment of venous stenosis of dysfunctional dialysis access. Study points are mentioned here. So what was important is that we used for the first time coated balloons, both in AVFs and AVGs. We didn't have pre-dilation, but only post-dilation. And sometimes coated balloons were undersized due to the limited diameters available to these balloons back then. And the time point was 1 year. As you can appreciate from the immediate results, in 11 out of 20 cases where we used coated balloons, we had to post-dilate in order to have a technical success of less than 30% residual stenosis. And at 1 year, there was a significant difference in favor of coated balloons with 35% versus 5% to the plain balloon angioplasty group. As this was the first study comparing coated balloons with plain balloon angioplasty for dialysis access, we tried to make a subgroup analysis between AVGs and AVFs. We saw that there was a statistically significant difference in AVGs, but not in AVFs, and there were only 7 cases in each group. So we wanted to figure out whether this was because the number of cases were so small, or because coated balloons actually don't function in fissulas. So the conclusion for our first study was that they do work in dialysis access. They mainly work as dark delivery devices. There was a post-dilation needed, and they're used in AVGs but not in AVFs. That's why we did our second study for coated balloons only in the fistulas. Again, study aims were the same, but only fistulas. Device access was even lower in that study, with only 7 cases without the need of post-dilation. To get a technical success in 13 cases, we had to post-dilate. Though target lesion primary patency at 1 year was significantly in favor of the coated balloon, and the same was for the access circuit primary patency at 1 year. So they do work in fistulas. They work as drug delivery devices, that's certain. We need to post-dilate or pre-dilate. And again, we used no pre-dilation, and there were some cases when the device was undersized compared to the final result. So what we're going to present you here is a retrospective study. For the last 5 years, we've been using coated balloons in dialysis access in our department. This is the flow chart. We had 70 patients. 8 patients were taken out due to corrupted data. So finally, we had 25 patients with AVGs, with 28 procedures, 29 devices, and 37 patients with AVFs, 60 procedures, 68 devices. So in 51 months, ending at August 14, 2014, in order to have a minimum of 6 months follow-up for patients, we had 62 patients in 88 procedures, and 97 devices were finally included. Outcome measures were target lesion primary patency, and we tried as secondary outcome measures to identify all the factors influencing target lesion primary patency and the complication rates. So these are the patient's baseline variables: age 60 years old, mainly men, and you can appreciate the rest of it. So we had both fistula, 37, and grafts. All of them were bright ones. Access age was 3.2 years plus minus 2.8. We had 38 out of 88 de novo lesions. The rest of the lesions there were re-interventions, and we had 8 cases of previous thrombosis. I mean, the patient actually presented with a thrombosed vascular access. Device variables, we had 3 different types: the impact, the Lutonics, and the Eurocore. Diameters were 5.8 plus minus 1.1 millimeters. Those are all devices that are up to 7 millimeters. They were not available until August 2014 in our department. Devices with a higher diameter, they are available now up to 12 millimeters. So the results: target lesion primary patency at 6 months was 70.3. At 1 year was 28.6%, which is more or less the same with the 35 we announced in the first study, and 2-year outcomes were 5.9%. There was no statistically significant difference between AVFs and AVGs, and the independent predictors for target lesion primary patency was that de novo lesions and vascular access age in less than 3 years was in favor of longer target lesion primary patency, while previous thrombosis and stroke were against longer target lesion primary patency. And you can see the results here for the de novo lesions, less than 3 years, younger vascular access, thrombosis, and stroke. So to conclude, platelet cell-coated balloons could offer a valid solution for the treatment of dialysis access, and larger randomized controlled trials are needed to prove the results and provide solid evidence. Thank you.